Everybody, this is Dr. April Demito. I'm the Assistant Director of the FNP program, and I put together a review of the final 4 weeks of Nursing 670. I think that you'll find this presentation helpful as you prepare in your study for your upcoming final exam. I like to start all of these sessions with a disclaimer that this is meant to help you prepare for your study and develop your study plan. It is not meant to be all-inclusive, so there are other things on the exam that you'll need to study for that will not be included in today's presentation. So this is just one of the many tools that you have to help you be successful when you take your final exam this upcoming week. Now let's talk about plantar fasciitis. And this is an inflammation. Anytime you see itis, it's going to be an inflammation of the right here and the plantar fascia. Nurses are prone for developing it. Anti-inflammatories can help, but I found what really helps the most are steroid injections. And the patient may need a couple of steroid injections. You can tell if someone has plantar fasciitis because when they get out of bed in the morning, oh my gosh, that first step is incredibly painful, and it gets a little bit better during the day. You want to instruct your patients to stop sports and exercise and avoid high impact activities until you can get that inflammation under control. Medial epicondylitis. This is elbow pain, and some people call it golfer's elbow or tennis elbow, but it causes this inflammation here in the medial epicondyle, and it's illustrated by severe elbow pain with wrist flexion, forearm pronation, or passive wrist extension. So that's one of the ways that you can identify whether or not the patient actually has a medial epicondylitis by performing those musculoskeletal examinations that you learned back in physical assessment course. Chronic arthritis. Now, with chronic arthritis, we want to avoid long-term NSAIDs because of the issues they can have on not only the stomach, but the kidneys as well. Capsaicin can be helpful, but we're going to learn in a couple of slides what the most aggressive treatment is, and it's a relatively new treatment that has made a great impact on arthritis. Those who have arthritis will typically experience stiffness, worse in the morning, swelling of the joints, and a good way to tell is if you shake someone's hand and you squeeze it and it elicits a pain response, then you're going to want to work that patient up for arthritis. Now, this is what I was talking about, the DMARDs, and this has now been recognized as an early treatment for arthritis. It helps to prevent long-term permanent damage to the joints. There are non-biologics and biologics. I see the biologics on television often, Humira, Enbrel. There's just a whole host of them. There are new ones that are given in pill form too, but essentially what they do is they suppress the immune response, so it does increase the risk of developing bacterial infection when you're on these things, so you have to be cautious, but it really helps in autoimmune disorders, not just in arthritis, but in psoriasis, ulcerative colitis, all those things. All right, so let's look at the COX inhibitors. There are 2 different types of COX inhibitors, COX-1 and COX-2. COX-1 regulates the mucin secretion in the stomach, and COX-2 promotes pain and inflammation. So we want to bind that so the COX isn't released. COX-2 doesn't promote that pain and inflammation. So aspirin is a COX-1, but it can cause stomach upset. Vioxx and Celebrex, they're not new anymore. They inhibit COX-2, so they suppress that immune response. And these have really helped people who are suffer from arthritis. However, we have found in recent years that there is a cardiac risk, so it can increase risk of heart attack. So you want to be cautious when using COX-2 inhibitors. Gabapentin works really well on nerve pain. We use this a lot in chronic pain with those who have trouble sleeping, as opposed to using opioids nowadays. I have many patients who get great relief from this. We also use this in nerve pain, so patients who have shingles will use that. Strep arthritis or rheumatic arthritis, it causes joint swelling and pain. It can last about a month. It's a sudden onset unilateral pain with redness and swelling. It's usually in the knee, but it can be other places. If you suspect that it may be a strep arthritis, culture the throat, urethra, cervix, rectum. To conclusively identify it, you can test the synovial fluid, do a culture on the synovial fluid. Avascular necrosis. This is a lack of blood supply to the head and neck of the major joints. This slide shows the femur, but it can affect other large joints as well. We see this in patients who have been treated with high-dose steroids, and in this case the patient will need a surgical consult because hip replacement surgery is really just about the only treatment you can do on patients who have avascular necrosis. Fibromyalgia is a condition that is central nervous system dysfunction is the key where fibromyalgia is concerned. Using a multidisciplinary approach in the treatment is a good method of management. And it's one of those diseases that is diagnosed by exclusion. So you test for a whole bunch of other things. Patients with fibromyalgia typically suffer from multifaceted conditions. The most prevalent component is pain. They feel as though they've got the flu all the time because they've got these terrible body aches and muscle pain. And it's been identified that they are usually in these 18 tender body points. Patients with fibromyalgia can suffer from cognitive impairment, blurry vision, fatigue, weight gain, anxiety, depression, dry eye, all sorts of things affiliated with that. Joint infection. Now this happens commonly I wouldn't say commonly, but if you have a joint infection, most often the patients who are going to get a joint infection are those with artificial joint implants. That's why it's so very important to prevent bone infection. Once you get a bone infection, it is really hard to get rid of it. You're going to be on antibiotics IV for weeks, maybe even months. And I'll tell you, I have AV necrosis, what we spoke of earlier, because I have had severe asthma, and I would have been on extremely high doses of prednisone in my life. So I ended up with AV necrosis. Now I was on Humira, a DMARD, for psoriatic arthritis. And when I had to have a joint replacement, my orthopedic surgeon insisted that I go off my DMARD because of the risk of joint infection. So I've been off it. I'm doing great, but we want to reduce the risk of any joint infection. So we want to pump up that immune system, except not for me because I have an overactive one. Okay, so here we have shoulder impingement syndrome. And you can see here's a nice healthy shoulder. And here we have the one with the reduced subacromial space. And this looks like it hurts, doesn't it? And as a provider, we're going to test for this by abducting the arm. If we abduct the arm, it should elicit a pain response. All right, here we are. Cervical myelopathy. This causes unilateral arm pain and weakness. It can cause some mild neck pain, and I thought it was strange when I was researching these topics. It can cause sexual dysfunction as well. So things to consider in patients who are experiencing cervical myelopathy. Degenerative disc disease. This, unfortunately, is one of those things that develops as we age. Many people have degenerative disc disease, and you can see the difference between the normal disc and that degenerated disc. This is going to be diagnosed with an MRI. Okay, ankylosing spondylitis. Now, this is it's a type of arthritis, but it affects the spine, and it happens usually in early adulthood. You can see here it's illustrated in this photograph of what it's supposed to look like, and then what your spine looks like when you have ankylosing spondylitis. The bone actually fuses here, and it causes pain and stiffness in the spine. All right. Polymyalgia rheumatica. I forgot the A on there. This is a rheumatic syndrome causing myalgia, stiffness, aching. It's worse in the morning. And with this one, patients can have fevers, depression, weight loss, anorexia. It's similar to fibromyalgia. The tenderness is rare in polymyalgia rheumatica, in contrast to fibromyalgia. So that's kind of what sets it apart from the other one, those tender points. It's treated most commonly with prednisone. So these patients are treated with high-dose prednisone, non-steroidal anti-inflammatories as well, to help with inflammation. Inflammatory bursitis, and it's an inflammation of the bursa. This patient will present with unilateral shoulder pain and limited active and passive range of motion. They are going to have, their shoulder is going to be erythematous, and they may have an anterior bulge in their shoulder from that swelling of the bursa. Diabetic foot pain. So I had a healthcare professional tell me once that diabetics should have a foot exam every time they go to the doctor. Even if it has nothing to do with anything, you should check their feet. Because, you know, once they get an infection there. I have a friend who is a diabetic, and she has lost 2 toes, and she has had a stress fracture in her foot and she's been in a cast for a year, and it still isn't healing. So if you have a diabetic and they are experiencing foot pain, you want to get an x-ray of that sooner than later, because we want to start treatment on those patients so it doesn't get worse. Rotator cuff injury. What sets this apart from the inflammation is that there's no loss of passive range of motion. So passive range of motion is fine with rotator cuff injury. It's the active range of motion that is interrupted. And this needs to be more often than not surgically repaired. All right, tenosynovitis. This is pain at the base of the thumb. It affects one hand typically. And you'll see this in patients who sew a lot or knit a lot. So it's a repetition. And to diagnose it, you're going to abduct the first metacarpal and hyperextend the phalanx metacarpal, and that will elicit a pain response. Okay, next slide. Reactive arthritis. This is used to be called Reiter syndrome. It's an autoimmune infection, occurs post-infection, and it can include a triad, and that triad is typically non-infectious urethritis, arthritis, and conjunctivitis. And so they can't see, they can't pee, and they can't climb a tree. That's what they say with those three things. It's strep related. A synovial fluid culture can be helpful in the diagnosis, and a culture of the throat and the rectum. And I have to tell you, as a provider, I have seen a correlation. I work in the acute care setting, and I've seen a correlation between strep cases and pink eye. So if I have a child that comes in with a crusty eye and I look at their throat and their throat looks yucky, I strep them, because I've seen that sometimes, not all the time, I wouldn't even say most of the time, but sometimes you'll see that correlation between those two. Serum calcitonin. This is produced by parafollicular C cells of the thyroid, and it lowers, it's a calcium lowering hormone, so it inhibits bone reabsorption by decreasing the number and activity of osteoclasts. So it acts to counter the parathyroid hormone. It inhibits bone reabsorption, so it causes serum calcium levels to fall. That's its purpose. All right, so some more autoimmune stuff. Systemic lupus. This is one of the more common autoimmune disorders. It's more common in women. Women who, or people who experience this, may have weight loss, fatigue, fever, increased infection, emotional lability. You'll know that they have that characteristic butterfly rash over the cheeks, and it's different. Their cheeks just aren't red. It's hard to explain, but the tissue, the swelling on the cheeks, it almost looks like scar tissue in a manner. They are sensitive to light, and lupus nephritis can occur too, so they might have proteinuria and increases their risk of vascular inflammation. Patients with systemic lupus who are have end-stage renal disease or end-stage kidney disease need a transplant. Now, the thing with autoimmune disorders is that we have a host of tests that we do. An ANA, you think, oh, if their ANA is negative, they don't have lupus, they don't have arthritis, but that's not the case. If you suspect a patient has an autoimmune disorder, I certainly recommend that you refer them to a rheumatologist, because they know the tests to check patients that your regular physician doesn't know. So if you suspect your patient has systemic lupus, draw a complement level. That's going to distinguish lupus from other autoimmune disorders. So for example, one of the tests they'll do when they believe someone has an autoimmune disorder is a test called a single-strand DNA test or a single-strand RNA test. Now, what does that tell us? Elevated levels show that that patient has an autoimmune disorder, but it doesn't define what it is. So we may know that something's going on with the immune system, but not be able to actually identify the condition that the patient is experiencing. But if you draw serum complement level, that will let you know if the patient does or does not have lupus. One of the problems with ANAs is they can flip. A patient can have an autoimmune disorder for many years before they end up with a positive ANA. Doesn't mean that they don't have an autoimmune disorder. We use a host of different medications for lupus. Prednisone is used readily. Also, hydroxychloroquine or Plaquenil is used a lot in lupus. Small vessel vasculitis. And this is a hypersensitivity vasculitis, so it's an immune complex mediated vasculitides. This is characterized by palpable purpura. So you know what purpura looks like if a patient has it. It looks like little red pinpoint dots, right? So that's purpura. What sets small cell vasculitis apart is that it's palpable. So don't be afraid to touch your patients. If a patient comes in and they have a rash like that, feel it. What does it feel like? Is it raised? Is it rough? So you need to become attuned to the different characteristics of conditions that your patients present with. Neuropsychiatric evaluation. Well, when we do these things, we want to help distinguish between depression, mood disorders, and dementia. So we start by assessing the patient's ability to cooperate with the test. The goal is to evaluate the cognition when neurodiagnostic tests are normal. So it's going to help assist the evaluation and counseling of dementia in the early stages and determine specific strengths, weaknesses, and recommend strategies for more efficient functioning. A stroke. Well, we know that there are two different types of strokes. And there's the ischemic and the hemorrhagic. All of those of you who work in healthcare may know what's the difference between these two. If someone comes in through the emergency department and you're concerned that they may be having a stroke, you're going to do your stroke alert, and they get a CAT scan right away to identify whether or not it is an ischemic or a hemorrhagic stroke. TPA in an ischemic stroke, you want to do it as soon as you can, and neuroconsult. Patients who present will often have visual field defects, ataxia, and headache. Sarcopenia. Oops, I lost my place in my slides. But this is a muscle wasting that occurs typically in older patients. And you can see the difference when you look at what the cells look like under the microscope. They're atrophying. So there's decreased muscle strength, and you may see weight loss affiliated with sarcopenia also. The elderly and exercise. We want to work diligently to encourage our elderly population to stay active. Exercise and activity helps to reduce depression in the elderly population and also helps extend good health. So we want to really promote exercise in our geriatric population. Oh, I lost another one. Low hemoglobin and elevated MCV. Now, what is that indicative of? If a patient presents, now we're looking at anemia, okay? So if we see that the MCV is elevated, we know that the patient, if you have a low hemoglobin, we've got low iron, right? But if we have an elevated MCV, we have macrocytic. What does macrocytic look? Well, you can see this picture down here. We have large cells. So we've got large cells, but not a lot of them. And these patients will present with weight loss and a red, beefy tongue. Okay, hemophilia. I think I've got 2 slides in here on this, which you don't necessarily need, but hemophilia is in males, and it is inherited blood disorder. Factor VIII, classic or type A, there's no cure. It is typically diagnosed, it is often diagnosed at birth when the male fetus is getting circumcised because it won't stop bleeding. Also, if you know of a family history of males who have had bleeding disorders, but it wasn't defined as hemophilia, it warrants a workup on that. So we've come a long way in the treatment of hemophilia. We can now administer those clotting factors and get that bleeding under control. All right, type 1 von Willebrand disease. This is the most common bleeding disorder that we have out there, and it is treated with desmopressin. Now, why is it treated with desmopressin? What do you think? Well, or cryoprecipitate too, but desmopressin is the one that's most commonly used, and that's because it's a vasoconstrictor, so it helps to stop the bleeding through constriction of the blood vessel. Lymphoma. Boy, I don't know how my slides got it all messed up. But the symptoms of lymphoma: swollen glands, typically in the neck, armpits, or groin, and they are not painful most of the time. They are fixed and firm, and the patient may have fever, fatigue, chills, facial flushing, weight loss. You would like to obtain a CBC with a differential and perhaps a lymph node biopsy. You want to rule out infection. If there's infection, they're usually tender, and it may even be red, or they may have had an infection, like they may have had strep throat or tonsillitis, and it just hasn't resolved yet. You want to consider that follicular lymphoma is the less aggressive of the lymphomas, and always consider an oncology consult. Now, this was a new aspect to me when I was doing research for this. Hodgkin's lymphoma prognostic score. Now, any of you who are in oncology may be familiar with it. I was not, and so it was a good learning experience for me. But it actually, this prognostic score helps to identify the prognosis of the patient by looking at these factors: the age, the stage, the gender, the hemoglobin count, white blood cell count, lymphocytes, and albumin. So all of those factors consider whether or not you have a good or poor prognosis with Hodgkin's lymphoma. All right, tumor lysis syndrome. This is a life-threatening metabolic disturbance that occurs in patients receiving chemotherapy. And it releases intracellular products into the systemic circulation. And the treatment for this is, it sounded weird to me because I was not familiar with this one either, is to prescribe allopurinol. So if we prescribe allopurinol, which is a treatment for gout, It will help to prevent tumor lysis syndrome from occurring in your patients. Dementia. Okay. Now, there are different forms of dementia. It's an umbrella term to describe lots of different conditions. Now, there are certain characteristics that your patient will elicit that helps you to identify what form of dementia that they have. Lewy body dementia, your patients will typically have visual hallucinations, and haloperidol will make it worse. So that's one of the antipsychotic meds that you would use in patients, but it doesn't improve the symptoms at all, it actually makes them worse. Delirium. And there are many causes, things that can precipitate delirium. It often occurs in the elderly a few days post-op. So you want to make sure that you are attending to their hydration status, because they may not be able to take responsibility for their hydration and toileting. So these things will typically pass. You just have to get through that stage. All right, Alzheimer's disease. Different stages of Alzheimer's, and you can see the duration. The mild cognitive impairment can last up to 7 years. Mild, 2 years, moderate, 2 years, and severe can last up to 3 years. Now, we've found that, again, keeping the Alzheimer's patient active and promoting exercise reduces the symptoms from progressing more quickly. Donepezil is one of the medications that we use, and we want to teach our patients, because remember, the caregivers are the ones that are going to be responsible for these patients, and they may be functioning fine all day, but once the sun starts to go down and that sundowner syndrome kicks in, they may begin to elicit symptoms of anger or fear. They may leave the house and go for a walk. So especially when the sun goes down, you have to keep a close eye on the Alzheimer's patient. Depression in the elderly is not an uncommon occurrence, and we may consider, oh, perhaps they have dementia or they're developing Alzheimer's disease. But if they have a negative cognitive function test, they may be depressed. They are losing loved ones. Their spouse that they've been with for 40 years has passed away. Their friends are all dying. So you may want to consider trying an antidepressant therapy. It may help them come out of this depression or ease it. Guillain-Barré syndrome, this is possibly autoimmune. They don't really know. It can be preceded by a mild respiratory or intestinal infection. It progresses over hours to days, and you'll see you begin by losing muscle tone. It starts with weakness, ataxia, and progresses to paralysis. It is diagnosed with a lumbar puncture. Bacterial meningitis, this is such a horrific disease. And I say to myself, as a provider, always think worst case scenario. So if I have a patient that comes in with a high fever and neck pain, I'm ruling out bacterial meningitis because it can progress to death in hours. So bacterial meningitis, I check for the Brzezinski sign, have them lay flat, lift up their neck and have them bend their knees. Can't do that if you have meningitis. We want to get antibiotics on board ASAP. So before we do anything, MRI, we're getting antibiotics on board. I had a friend who actually lost her 2-year-old to bacterial meningitis, and she took her to the emergency room twice, and twice the emergency room said she had the flu. So they didn't use that worst case scenario type of thought process. So unfortunately, she lost her daughter. So don't make that same mistake. I also encourage all college age students. We have that bacterial meningitis vaccine now. What's it called? Oh my gosh, I think it's Bexora. I recommend it to every young person going off to college that's coming in for physicals in my clinic. Let's get this on board. It's a 2, 1, you get 1, and then you get 1 at least a month later. Parkinson's disease. We diagnose Parkinson's disease with 2 of the cardinal symptoms that you see here that improve with levodopa. And when the thing with levodopa is it doesn't work well over time. So over time it begins to not work as well. So we're going to add amantadine to the levodopa once that starts not working as great. Seizure treatment. Okay, so when we're looking at seizures, and the treatment of seizures has come a long way. We used to use gabapentin in the treatment of seizures. That was like the #1 drug we used back a long time ago, but it isn't anymore. Consider the type of seizure that the patient is having, and that's going to directly correlate with the treatment that we do. So if we have a patient whose seizures present typically with eye twitching, visual hallucinations, the origin is going to be in the occipital lobe of the brain. And if we have a patient who has focal and complex partial seizures, the treatment is going to be different. So you can see with the partial or complex seizures, we're going to use carbazepine. And if we have a persistent ongoing seizure, and these are those status epilepticus that won't stop, lorazepam, and monitor the cardiorespiratory status, because we don't want to give them so much that we inhibit their respiratory center. All right, pain characteristics. Now, as a provider, these characteristics are going to bring new meaning. And I like to have my patients describe in as much detail as they possibly can when they are describing their pain to me. Is it stabbing? Is it throbbing? Those are examples of somatic pain. And is there anything that makes it worse? Is there anything that makes it better? Is it shooting? Does it feel hot? Is it throbbing? With the different characteristics of pain, we're also going to consider what we're going to treat them with. Now, with fibromyalgia pain, remember that is the CNS is kind of messed up, nerve pain. We've found that SSRIs, actually an antidepressant, works really well to treat the pain in fibromyalgia patients. So don't be afraid to think outside of the box, using the capsaicin, using electronic stimulating devices. All of those things can help a lot in pain. Restless leg syndrome. This happens when people typically will go to bed. They have involuntary limb movements, and it can be connected with an iron deficiency or vitamin C deficiency. Try to have your patients take hot baths before bed. Exercise will help also. And I'm trying to think of some other treatments. Oh, if you put, you can use that TENS device before bed, or use a capsaicin cream on your legs before you go to bed. Those things all help also. There's my other slide for hemophilia that we don't really need. Sleep apnea. Now, people who are experiencing severe daytime sleepiness should be checked for sleep apnea. and it can cause a whole host of issues: snoring, dry mouth, morning headache. Uh, if the patient has daytime sleepiness and snores, but they don't have any health problems, they're okay. There isn't any reason that they can't have an unattended out-of-center sleep study. So that's a sleep study that's done at home. It's all recorded on a computer and then it's analyzed after. Patients who have health issues, those typically are the ones that need to have the sleep study done in a sleep center. But if they're healthy, there isn't any reason they can't have it at home. Now, elevated eosinophils. Now, this is something that you don't see often because the eosinophil count is typically very low. But in the event that you have elevated eosinophils, you may want to consider the patient may have a parasitic infection or Churg-Strauss syndrome. So it can be issues outside, or allergic reactions can cause that also. Wiskott-Aldrich syndrome. Now this was new to me also, but it's an immune deficiency characteristic of thrombocytopenia and eczema. So they have low platelets and eczema. These patients often will have recurrent pneumonia with increased bleeding, bruising, and then the eczema, and it is an immunodeficiency. X-linked recessive disease. The only treatment is a bone marrow transplant. So you can't give them like IgE antibodies. It doesn't work. The Philadelphia chromosome test. Okay. This is a test that you do to identify CML leukemia. So this is the test, the conclusive test for leukemia. Now, cancer pain treatment. Nowadays, we've become so consumed with the opioid crisis that's out there. We need to remember that those who are experiencing the pain of cancer are the outliers. It's okay for cancer patients to have morphine and opioids for their severe pain. Sometimes patients will not want it because of the side effects that go along with opioid treatment, like constipation. So we need to consider those things too, how to treat that constipation. Palliative care. When we're having conversations with our patients and our patient's family related to palliative care, we must ensure we have communicated to them that this may hasten death. Conversations about palliative care is something that a healthcare provider should have during normal health visits with their patients so that they know what their end of life or wishes are. And you can see that palliative care is the outlier. So living with a life-limiting illness with any prognosis, we're managing the symptoms. It's different from hospice care. So with hospice care, we kind of don't do any treatment, but with palliative care, you still may, because you want to maximize the quality of the life that you have. Hypertension and albuminuria. Okay. If you have a patient who has hypertension and they're spilling protein, you need to consult with a nephrologist. They're independent variables that predict the long-term decline in renal function. So renal disease is a cause and consequence of hypertension. I had a friend once who had hypertension and they couldn't find a cause. Finally, she went to a nephrologist. She actually had narrowing of the renal arteries and had to have stents put in her renal arteries. So life experience can bring a lot to the table when you're becoming a healthcare provider. Acutely elevated calcium levels. We're going to treat this with IV normal saline. Acutely elevated potassium. In the renal failed patient, we're going to treat with insulin and glucose infusions. Acute low serum calcium with low serum albumin. We're going to correct this with serum electrolytes. You know, the electrolytes, I've taught pathophysiology at the undergrad and the graduate level, and I think it's so fascinating, all those little electrolytes, how, you know, salt loves water and potassium hates salt, and how all of them interact with each other. So if you have issues, you need to look at all of the electrolytes to correct the status. A carpal spasm. This is interesting. Did you ever perform a blood pressure on someone and have their arm jerk up? Well, that's a carpal spasm, and it is typical in someone who has low calcium. You want to check the magnesium level and vitamin D level, and this is the response you'd see with blood pressure cuff. Adrenocortical deficiency. All right, let me find my slide. I have all my notes on my slide. Okay, so this is going to affect cortisol and aldosterone release. And it can be first degree with adrenal gland dysfunction or secondary by a pituitary dysfunction. You'll see this with patients who have a normal renal function but an elevated potassium level. So if you have a patient with a normal renal function but yet their potassium is elevated, you may want to consider investigating adrenal insufficiency in your patient. SIADH, all right, syndrome of inappropriate ADH secretion. All right, so this is directly related to the hypothalamus and how the anterior pituitary works, all of those crazy things. So the hypothalamus makes ADH, and that ADH moves to the posterior pituitary gland. It's secreted according to the plasma osmolarity of ADH at the collecting tubules of the kidney, and it causes water reabsorption. SIADH causes continued ADH secretion. So these patients may need to be on fluid restriction, and it's typically about 500 milliliters a day until this gets under control. Thiazide diuretics, the mechanism of action you can see here. The sodium and chloride are not reabsorbed, resulting in an increased excretion of these ions. It has a risk of dehydration, so we want to hydrate these patients if they come in symptomatic, they're dehydrated, with a 3% NaCl sodium chloride solution. Metabolic syndrome in patients, it's diagnostic. We diagnose metabolic syndrome in a patient who has elevated waist circumference, an HDL of greater than 45, triglycerides of greater than 150, and we typically will treat metabolic syndrome with metformin. So even if they don't have diabetes, we're going to treat them with metformin because it decreases the PA1 levels, so PAI1 levels, and that's the plasminogen activator inhibitor. And it increases the risk of thrombus and atherosclerosis. So metformin will help to reduce those levels, to reduce the risk of atherosclerosis. All right, hyperparathyroidism. This is typically due to an inappropriate secretion of parathyroid hormone, along with hypercalcemia. So you're going to monitor the calcium, creatinine, and do an annual bone density on these patients. Patients with hyperparathyroidism often get kidney stones. They can have low bone density also because the bone's not being reabsorbed. Diabetes. Okay, now type 2 diabetes that I can remember when I was in nursing school a million years ago, they never would consider giving type 2 diabetic insulin, but that whole course has changed. And it isn't uncommon now for patients with diabetes or type 2 diabetes to need insulin after a year of treatment. Sometimes, in fact, one of our patients came into our acute care clinic with symptoms of a UTI, and there was glucose in the urine, so we did a blood sugar on her, and it was over 300, and she was young. We sent her to the ED, and sure enough, she actually was a type 1 diabetic. She was young. By today's standards, A1C is considered diagnostic. It wasn't always considered a diagnostic test. Lipid management in the diabetic patient. Okay. Not all diabetic patients need to be put on a statin. So we need to consider whether they need to be put on one or not. If the lower LDL cholesterol goal of less than 70 can be obtained by using a high-dose statin, we want to use that in individuals with an overt cardiovascular disease problem. So if individuals don't have overt cardiovascular disease, we can keep an LDL cholesterol less than 100. With overt cardiovascular disease, we're going to use a high-dose statin. And anybody on a high-dose statin we need to keep a close eye on. Muscle cramps, muscle pain, we need to check that CK level in patients to ensure we're not getting any complications, because statins are not without risk. And PAI levels, I spoke to this a little bit earlier, increased levels increases the risk of arterial thrombosis. Thyroid levels, okay. Now, this is what our normal thyroid levels are. We look at the TSH first. Elevated TSH indicates that we may have hypoactive thyroid. A low TSH indicates a hyperthyroid may be occurring. Now, in the postpartum population, the TSH may be elevated on a transient level, so it's not a good indicator. You may want to retest in 6 months postpartum to see if that TSH is still elevated. Okay. Now, anemia. Always want to consider in patients who present with a fatigue, increased heart rate, shortness of breath, that they may have, they're at risk of anemia. So you don't want to just do a CBC with a dip or an H&H. You want to do a ferritin level. Ferritin levels are of paramount importance when you're identifying whether or not the patient has anemia. Breast cancer, these are some slides I added after I completed the presentation. With breast cancer patients, those who are in remission that develop low back pain, we want to do an MRI on them. The reason being we're concerned about metastasis. So patients who experience low back pain with a history of breast cancer, I want to make sure that they don't have metastatic breast cancer because where's it going to go? It's going to go to the bone, lungs, brain. Those are the most common points of metastasis in the cancer patient. So we want to do an MRI just to rule that out right away, because delay of treatment is not something that we want in our cancer patients. So I hope that you found this presentation helpful. Please let me know if you do. And remember, the one thing I want to point out to you is to make sure that you read your test questions completely. Take your time. I find those who have the greatest errors in exams took their test too quickly, misread the questions, didn't answer what the question was asking, or changed their answers. Most of the time, your original answer is the correct one, so be very cautious about changing your answers. Also, this is not meant to be your only method of studying for your upcoming final exam. The purpose of this presentation is to give you a review of the material that you've covered in the last 4 weeks of your course. So I hope that you find this helpful, and good luck as you move forward into 671.